Hi. I had given this talk recently at the International Cancer Congress, and I thought I'd just share this with you. So, this was an approach to percutaneous biopsy of MSK tumors. And let's just start straight off. This is a 60-year-old man with a distal femur lesion. I've done this case earlier, and you can see it in the table of contents at ctbiopsy.com. But here is a metaphyseal, epimetaphyseal lesion in an elderly. You can see what it looks like on the CT scan. And the question is, what will be your biopsy path? Would you go anteromedially, or would you take any of these posterior approaches? And this is what I did, just went anteriorly. This is where the incision would be taken for the surgery. And you can see that I've used a 16 gauge, and then I've deployed the gun here, and then taken some material more distally, then something from the center, including the septum here. And that's pretty much at the end of the biopsy. So the diagnosis was clear cell chondrosarcoma. And the rule with most bone and soft tissue tumors is that if the lesion is aggressive, and therefore you actually use the rule for pretty much all tumors because you don't always know the histopath in advance, obviously. So the rule is to biopsy along the line of the expected surgical incision, since the tract has to be excised to prevent seeding and recurrence along the tract. This is the article from Radiographics. It's from 2007, but it still stands the test of time, and it's just a very good idea to keep this article somewhere with you on a phone or a tablet, or just print this out and paste it on the board in front of you, or pin it on the board in front of you if you're doing MSK biopsies. It is also a good idea to check with the orthopedic surgeon who has sent the patient, and then figure out what the best approach for the biopsy would be. So when we're doing biopsies, we use we can use fluoro, but this is usually done by non-radiologists for large tumors. Ultrasound, which is very good for soft tissue tumors. CT used most commonly for most bone tumors. And MR, it is used in some research centers. It's not used in India. And even when it is available, it's extremely cumbersome. I mean, CT-guided biopsy is the actual procedure. From the time you put a marker on the patient to the time you finish is between 10 to 15 minutes at the most. Sometimes it takes about 14, 15 minutes in the spine, and a little setup of 10 minutes before, and kind of taking care of the patient on table 10 minutes after, whereas MR would take much, much longer. So the standard protocols are pretty much the same. Pre-procedural, we must understand the case and the approach and discuss with the referring doctor or the ortho-onco colleague. Stop antiplatelets and other blood thinners for 3 to 5 days, depending on the anticoagulant and the procedure. But again, with bone tumors, if you're going straight into the bone with nothing in the way, even if the patient is on antiplatelets and the cardiologist refuses to stop it, as long as the INR is less than 1.5, it's fine to go ahead. In fact, in the appendicular skeleton, we can even biopsy with higher INRs because we can compress. And if you can compress, then you can stem the bleeding if it occurs. Platelets, again, this is only when the patient is seriously sick. Otherwise, and I work in a freestanding diagnostic center, all the patients who walk in obviously would have normal platelets, and we don't actually measure them. Counseling is extremely important because the patient and their relatives should know what to expect and what is going to happen. We now use tranexamic acid prophylaxis in patients where we think there is an increased risk of bleeding, typically with soft tissue tumors, not always with bone tumors. The data on this is not that great as far as guided biopsies are concerned, but the data for reducing the risk of bleeding and the complications from bleeding with road traffic accidents, etc., is reasonably good. During the procedure, we use intravenous sedation in most situations. Intravenous contrast with bone and soft tissue tumors is not usually used. I mean, this is more for liver, pancreas, etc. If the patient bleeds, we give tranexamic acid. And then obviously you have to use the appropriate needles and guns, take material and formalin for histopathology. And if there is even the slightest doubt about the diagnosis, then in TB endemic countries, it's always a good idea to take material for microbiology. So there are some situations where you know it's an obvious chondrosarcoma or an osteosarcoma, then it's fine because you don't need to waste material for microbiology. But in any, even the slightest of indeterminate situations, you would want to do this. Otherwise, just make it a protocol and take a little bit for microbiology in every patient. We keep the patient in the recovery room for a couple of hours if they've been sedated and until they're fully conscious, which could take a little longer as well. If there is continuous pain, we use intramuscular or intravenous analgesia for the day and then follow up after 6 hours on phone and after 24 hours. These are the tools of our trade. We rely a lot on the 11 gauge or the 13 gauge diamond tipped bone biopsy needle. This is by Cook, but you have other vendors as well. And this allows us to penetrate even the thickest of bones in conjunction with this mallet or hammer. We use 14 to 18 semi-automatic gun. It could be Cook, it could be Bard. These are the two we use. And rarely, very rarely, if the bone is very, very sclerotic, we use a Jamshidi. So a few examples. This is a 29-year-old with ankle pain. These are the approaches. This patient has a giant cell tumor. It's T2 dark. There are a few fluid levels. And this is the line of expected surgical incision. And so that's how I did the biopsy. And you have to tailor the approach based on what is best for getting material. Now, here we have this patient, looks like a fibrosis lesion. They were insistent on a biopsy. Now, you could go in transverse, but that makes no sense because that increases the risk of puncturing the pleura. And so a good idea is to go along the long axis of the lesion in the rib. Now here, this is a simple and straightforward biopsy, and I've used an approach that is along the plane of the expected surgical incision if the patient were to go for surgery. A lesion like this in the supraacetabular region, there are so many ways to approach this. You could go, transiliacus into the lesion, and for some reason, a lot of radiologists are resistant to using bone to get to lesions. But you can see here that if you went through the anteroinferior iliac spine, you'd actually have the safest and the easiest approach to the lesion. Nothing really comes in the way. And you go in straight. That's what we did for this patient who had Langerhans cell histiocytosis. Or for that matter, a lesion like this in the femoral neck. Now, our pre-test probability was either chondroblastoma or LCH, more likely LCH or osteomyelitis, sorry, because this was a metaphyseal lesion and not epiphyseal. So I'm just trying to remember the case a little bit anyway. And so you have these three approaches. And I mean, the anterior approach is fine if you think this is going to be benign, because then it doesn't really matter. But look at the number of muscles you're going through. You also have the profunda crossing over somewhere or the other. But if you were to take the transtrochanteric approach, you do need to be very good with your targeting. But otherwise, nothing really comes in the way. And that's what we did. And this turned out to be LCH. You have to be a little creative in the spine. So in the cervical spine, in the supine position, for C1, you might need to go transoral, anterolateral, posterolateral for the other levels. For C1, OC1, C2, you can use the prone position and you can get into the lateral mass in some situations. And you can sometimes use the decubitus position. So let's look at this patient with a C3 vertebral body lesion that you can see here very well. Now, what are the approaches? You could actually go transoral, but that's not something the radiologists do. Plus, you have to use anesthesia with an endotracheal tube and all of that. Then you have the yellow line, which is retromandibular. You can go retrocarotid, and then you can just use posterolateral approach, just anterior to the foramen transosarium. Now, we actually called the patient in a day before, gave contrast, turned the head to the opposite side, and I found an extremely easy retrocarotid route into the lesion, which is what we finally did using a simple 18-gauge semi-automatic gun. Deployed the gun here, and that's the biopsy that I've done. Right, and this turned out to be plasmacytoma. In the dorsal spine, we have these approaches, plus you could do decubitus. In this patient, we've done both transpedicle and perivertebral. And I'll come to this again because this patient had suspected tuberculosis. And you have to maximize the tissue that you get. Pus is always better than tissue when it comes to microbiology testing. And so we just go in wherever we think we would get pus and we would get the maximum amount of tissue to allow us to get a diagnosis. On the MR, there was a collection here, there was an osteolytic lesion here, so we sampled both. And that increases the time a little bit, but it's worth the effort. Now, here we wanted to go into this collection. There was no real approach, so I went through the rib. So it's like a transosseous route. This is costovertebral, the safest and the best route to take if the lesion is in the middle of the body. And again, perivertebral, where you just go in next to the vertebral body if there is a collection and biopsy it. These are the approaches for lumbar spine, transpedicular, perivertebral, and you could go decubitus. I have discussed this earlier. This patient had metastasis from myeloma, and we actually made the diagnosis on table when we got black material coming out of this lesion in the vertebral body. But that's a transpedicular approach. Very safe because nothing comes in the way. The only thing you have is the perispinous muscle here. For this lesion, I went perivertebral, perifacetal. You have to be a little careful about the nerve root coming here, but you're not really going to injure it. At the most, you'll touch it, which is why the patients have to be sedated, and you can use a little local anesthesia here to anesthetize the nerve. Now, this patient with suspected TB spine, again, I've used two perivertebral approaches here, one next to the osteolytic lesion, the other a little laterally, so as to get as much pus as possible to get the diagnosis. You rarely need to use decubitus approaches, but this one, the patient had a posterior vertebral lesion that I couldn't reach using a transpedicular approach, and then I did this using a transpsoas decubitus approach. The same thing at L5S1. Here you have the sacral ala to help you with, and you can see here an L5S1 discitis. And all I had to do was go through the sacrum into the disc, and that the angulation helps to do this. And the sacral ala is one of the best bones to go through. It's thin, it doesn't pain a lot, it's easy to penetrate, and you're in the lesion in no time, and you can get enough material for a biopsy. So remember that any route through bone is safe and easy. So here I've gone through the facet in this post-operative patient with suspected post-operative infection. And that's safe because, again, nothing comes in the way and it's easy to penetrate and get into. And this patient who had an osteolytic lesion in the middle of the S1 vertebra, I just used a sacroiliac route, and that's fine as well. And all this is okay, right? Getting into the lesion, targeting it, finding creative approaches, making sure that we are along the line of expected incision when it comes to appendicular lesions. But that's not enough. At the end of the day, the idea of doing a biopsy is to get a diagnosis. And so while technical success is great, you need diagnostic success. And how do we maximize our ability to get an answer? So here's a 31-year-old, had a right shoulder swelling. I mean, literally, the patient was absolutely fine, let's say yesterday. And then today he comes in, says, okay, let me just get an x-ray done because I have a little bit of swelling. And on the x-ray, you not only see a chondroid tumor, you also see extensive lung lesions. The MR, in fact, showed multiple, multicentric lesions. Patient had some weird biopsy done blindly, or I don't know, C-arm guided. It was all negative, and you just wonder what that person was doing, when you have this kind of pathology. Now, the idea was, and we did get a PET done prior to make sure that we knew what we were dealing with. And the idea is it's a tumor. You also know that it's metastasized. And you also know, therefore, that material is going to be required for mutation and genetic studies. And so you need to obtain as much material as possible. So I first went into the bone using a 14 gauge semi-automatic gun, then into the soft tissue to obtain about 12 cores, 6 each, so that there would be enough material for every test that anybody wanted to do. So this was a mesenchymal chondrosarcoma. So to summarize the points that help us with higher diagnostic yield. This one is obviously use the correct approach based on the plane of prospective surgery and discuss with the orthopedic oncosurgeon in advance. The largest needle possible that is safe for that particular setting. Penetrate the bone either using the needle of the gun if it's very thin, in which case you try and use a 16 or a 14, even 18, depending on what is safe. But otherwise, use 11 gauge or a 13 gauge bone biopsy needle. And then once you've penetrated the bone, use the semi-automatic gun through the 11 or the 13 gauge bone biopsy needle. Sedate liberally. Many of these lesions are painful. You need the patient still so that you can finish the biopsy and avoid complications. Remember, TB lesions are painful. And so it's very, very important when you're dealing with, even with collections, even with what we used to call cold abscesses. They're not cold, they have pus in them. And, you should learn how to sedate liberally. Now, there are some settings where you can get away with periosteal infiltration. Remember, things like aneurysmal bone cysts, giant cell tumors are not actually painful. And you can often just use a lot of periosteal infiltration with local anesthetic and then just penetrate the bone and do the biopsy. Use guns with a longer throat, 20 or 30, unless the Z-axis or the AP diameter does not allow that. And take 1 core per formalin vial. This is what my pathologist has told me to do, so that each vial is a block, and therefore even the pathologist in their enthusiasm will not exhaust the blocks just to get a diagnosis and do immunohistochemistry, because then you're using each block judiciously. So you use a couple of blocks for histopath, maybe 1 or 2 blocks for immunohistochemistry, and the rest are left over for further studies as and when required. And as I said earlier, even if there is a 0.5% possibility of a non-neoplastic etiology, it's a good idea. And maybe it's just a good idea in every patient to take material for microbiology, in which case, again, it's 1 core per vial. Of course, if you get pus, then you distribute it for the various tests that are required, TB being preeminent, and then it could be aerobic and fungal culture as well. Thank you so much for listening to me, and I hope this is